The next speaker will be Dr. Roshan Ryan. The topic will be OSA through the eyes of dentistry.
We are running late by an hour, I think. Yeah, thanks a lot. Thank you to Ilcon and Dr. Shankar and for giving me this wonderful opportunity to be a part of this here in this event. And my journey with ENT started like a snail in 2017 when I took a few study models and went to Madras ENT Research Foundation like a postgraduate, showed a little models with some little bit appliances, and there was one person, Dr. Mohan Kameswaran said, who sat on a Sunday evening with me just because a WhatsApp message was given to Dr. Vijay, and that's where the snail journey started, and now it has metamorphosed into a butterfly. And today, last year, he inaugurated my clinic. It was NABH accredited, and he's like a father figure to me as well, like how he's a godfather to you all. So OSA management through the eyes of dentistry, how we can look into it. A quick brush through a little bit of high impact evidence-based journals in ENT, which says that there is a lot of louder conversation between ENT and dentistry in 2025, which started as a very small thing like a dental appliance, which could be a part of a game changer in OSA in 1987. Maxillomandibular advancement can be considered a very potent tool as a surgical option when a lot of refractory surgical procedures in OSA are not able to benefit. And orthodontic treatments can also play a major role in improving OSA and snoring in pediatric individuals. With the table of contents for today, we'll have a little bit of facial phenotypes. What are the signs and symptoms commonly seen pertaining to OSA? How do we see the problem and what do we do? And how the investigation workflow is and what are the management options we have? Well, I'm not going to talk about what is OSA, and because if I talk, that's going to be an obstruction from the room itself because everybody has started here with this and there are many more better people to talk about this. Well, what I would like to say is OSA is a past of an SDB. Sleep disturbed breathing is the more broader spectrum we use, and of course it's a metabolic disorder with various mild, moderate, severe, etc. And we look at sleep studies, dyes, everything, and that's how we look at the problem. So SDB is a more encompassed term which we normally use, in which OSA also fits into that. Well, when we look at the dental facial phenotypes, there are three profiles we always look at: the straight profile, the convex profile, and the concave profile. Well, a convex profile and a concave profile, both these kind of profiles are prone to have an OSA or a sleep disturbed breathing, okay? So we look at the cranial base. From the cranial base, we look at the maxilla and the mandible. That's how we look into this. And of course, when it comes to the facial features, the soft tissue also plays a major role. So how we look and how you look may be a problem. What you look at, maybe a straight profile you look like, but the soft tissue will totally camouflage the whole scenario. So a lateral surf will be a good choice to look from the cranial base how it looks like, a straight profile, a convex profile, or a concave profile. And a lateral surf will also give you a greater idea of how the airway can look like, whether you have a narrow airway or a normal airway, or there is an obstruction, etc. Well, this is a normal overjet what you see. This is ABC for dentistry, but it could be XYZ for ENT. So excessive proclination, that's how it looks like. A normal proclination should be only 2 mm. If it is more than that, it's a what you see is this an excessive proclination. Deep bite, reverse overbite, all these things can cause a little bit of narrowing of the maxilla, or the mandible can be a little backward, causing obstruction in the airway. Well, the signs and symptoms, what we see, I'll put it as a small mnemonic TNPPSC. Tongue thrusting is very common, where the tongue swallow pattern is not good. A narrow maxilla, posterior crossbite. This is how a posterior crossbite looks like. Normally the upper teeth has to overlap the lower teeth. Now sometimes the upper teeth is inside and the lower teeth is outside. Protruded upper front teeth, that's what we call it as excessive overjet. Convex facial profile with submental fat deposition. This is a very characteristic phenotype for having OSA or an SDB issues. A short mandible. Okay. 4 T's are bad from a dental perspective when we look at OSAs. Lip tie is bad because there are 26 muscles which will play a role in the swallow pattern or the speech, etc. Tongue tie, tongue posture, and the tongue swallow pattern. Normally the tongue has to touch the palate and swallow. When there is a tongue thrust, they touch the teeth and swallow, and this corresponding open bite and a short mandible. So how do we see? We see this as a three-way phenomena. Normally what we call it as a chicken and egg dilemma. Or chick and egg dilemma. It could be an anatomical origin, as the craniofacial phenotype is a problem which causes the mouth breathing, which indirectly causes adenotonsillar hypertrophy and a reduced muscle tone. Or it could be generally a habitual mouth breathing causing adenotonsillar hypertrophy, which in turn changes the orofacial structures because the function decides the form according to Melvin-Mouse functional matrix theory, which in causes the reduced muscle tone, or per se the ENT pathology, which is primary in nature, which causes the mouth breathing, which in turn causes the reduced muscle tone, worsening the orofacial features. It can be all the three-way round, okay? So the ENT pathology, we need to take out the pathology or the obstruction. When it comes to the muscle tone loss, which is the end result, we need to improve the muscle tone by means of myofunctional therapy. And when it comes to anatomy, we need to correct it by orodental devices. So the speaker's note, what I always put in my slides, what starts as an anatomical issue could be pathological in nature, which can become habitual. What primarily starts as a habitual origin can become a pathology, which can alter the anatomy. Or what starts as a pathology can become habitual, which can also alter the anatomy. When all these three things are put together, the anatomy, the pathology, and the habitual, the expression of the problem is alarming in nature. That is where the patient lands up to you. So what do we do? There is an evaluation workflow. Every patient who walks into the office, 6 years and above, we have a breathing questionnaire being given to the patient. 4 to 5 positive signs is a red flag for us. And clinical orthodontic evaluation, we do the patient. Then, looking with the pediatric OSA perspective or the adult OSA perspective, we start looking at the patient. So OSA-based dental evaluation, followed by the Mallampati score or the nasopharyngeal space, everything is being evaluated. You know better about this. I don't want to go into details about this. Then the diagnostic workflow comes. How do we do the diagnostic workflow? Screening, clinical evaluation, 4 to 5 positive signs, referral to the ENT to look for any obstructions, airway space assessment, if any, then treatment with oral appliances. Investigations, what do we look into? We take good pictures, about 10 pictures, intraoral is about 6. This is the protocol which we follow. Then the extraoral, the facial profile, we assess, whether it's a concave profile, a convex profile, or a straight profile. Then we take a OPG to evaluate the dental evaluation status, how the teeth are, and of course the joint also we look into. Then we take a lateral shift to assess the airway along with assessment of the bony condition to the cranioface. Then of course CBCT also plays a major role nowadays to assess the airway volume. This is the thing, and there are airway software tools to assess the airway in the CBCT imbibed in it nowadays. So from the PNS and the cellular to the anterior border, this is how we measure the total airway space. And these are the anatomic landmarks we assess. And what is the airway volume? What is normal? What is abnormal? Just a small insight about this. 9,000 to 12,000 to 20,000 cubic millimeter is considered normal for adults. For children between 6 to 12 years, 4,000 to 9,000, but in adolescents, it's about 9,000 to 12,000 cubic millimeter. This is considered normal. Anywhere the threshold of cubic millimeter of airway is below 4,000 cubic millimeter is a potential airway compromise. Study models we take and do an analysis, and now comes the management. Management, we look at 2 categories, growing child, grown child, and completely an adult. When the arch development, we look at expansion, we look at growth modifiers like headgears and twin block in case of growing child. Anteroposterior correction, we look at face mask, reversible headgears. I will be showing a couple of pictures of my cases, what we have done. It's a grown child, we look at MARPE, it's a mini screw assisted rapid palatal expansion. Mandibular repositioning devices, when it's a growing child, it's a Herbst appliance. It's an adult, we use mandibular advancement devices and basic anti-snoring trays. And if it's purely habitual in nature, it's a habit correction by means of myofunctional training or a tongue crib or an oral screen or a myobrace an adult. When it's a surgical option, grown, completely craniofacial issue, the bony problem, bony compartment is the problem, then you look at maxillomandibular advancement, genioglossus advancement, etc. So if it's a purely a habitual or a myofunctional nature, but the muscle is the problem, we look at these kind of appliances called the oral screen, a tongue crib to control the tongue swallow pattern, which will improve the bite of the patient and the teeth alignment and the soft tissue profile. When it's purely a myofunctional, the muscle alone is a problem, then we look at these kind of devices like myobrace. It's for juniors, kids, teens and adults based on the size and the silicon rubber material, as they grow older, it becomes a little more harder in nature rather than a little more flexible in nature for the younger kids. And of course, Myo tape is also an added device which we can use along with Myo brace to improve the lip seal while they are sleeping. Well, we also look at expansion. This is an intraoral distractor, which is a non-invasive, non-surgical distractor, which is called Hyrax appliance. Growing child, we give this to expand the maxilla. When you expand the maxilla, there is a lot of literature to say that it also improves the sinus flow. The maxillary sinus gets improved, and the breathing pattern, the nasal resistance is less, and the breathing is enhanced. So this is how a narrow maxilla can be improvised to get a maxilla like this. Thereby, so orthodontics is not about improving the cosmetic correction, it's more also about improving the function of the patient. So a grown child like an adolescent will go in for a MARPE, mini screw assisted rapid palatal expansion, which is like this, where a temporary anchorage device is submerged bicortically to the roof and the floor of the sinus, and CBCT helps us to do the planning to exactly diagnose what type of screw, what length which you can place, so that that's a bicortical engagement. So when it's grown completely, you do a split. This is called surgically assisted rapid palatal expansion along with braces done in under GA. We use a mid-palatine split and also a Leafort 1 osteotomy cut. And intraorally in the surgery itself, we'll place the appliance and we'll activate the appliance and see whether the maxilla is getting distracted. Coming to mandibular advancement, growing children, we use twin block with Hyrax appliance. So this is the results what we achieve after the expansion and after the mandibular advancement. Twin block, as the name suggests, it's a twin. So it also expands the maxilla, also advances the mandible. Mandibular advancement alone, growing children, we go in for something like this, a Herbst appliance, which can get a good result. When it's a grown person, we go in for mandibular advancement devices. So when we do a proper sleep study and then evaluate, and if they are resistant to CPAP or intolerant to CPAP, then mandibular advancement devices are suggested to them. So you can see a significant improvement in the airway after the mandibular advancement devices are placed. So this is how the mandibular advancement device looks like. So this is a more normal fitting protocol for MAD. This is too technical details. It's more for dental professionals to assess the bite, how much bite we need to enhance to get the mandibular advancement device, not damaging the temporomandibular joint and the other orofacial muscle. From the bite, what is there right now for the patient. So this protocol which we follow. So basically the MAD fitting protocol says that mild to moderate OSA, these are very good. Primarily they are snorers and CPAP intolerant patients. So this is the George protrusion measurement and mat fitting protocol. So this is how an anti-snoring device looks like, trying to help the mandible to be brought forward so that airway is improved. Suppose you want to improve the maxilla as well as the mandible, like a reverse overjet like this. We go in for reverse pull headgear along with a device like an intraoral plate to improve the maxilla as well as to control the growth of the mandible. So the profile is also improved, the breathing capacity is also enhanced. Here the problem is increased skeletal maxillary growth, which is not allowing the lips to close properly. So we go in for a twin block with headgear. Okay, so this is how the problem is, and this is how we achieve the results after these appliances. So adult surgical options, we look at Leafort 1 osteotomy to bring the maxilla forward. Mandible is a BSSO osteotomy to bring the mandible forward, maxillomandibular advancement. So this is not under my purview. The OMFS team takes care of this, so I have not shared any cases as such in this presentation. So these are a couple of OMFT exercises which we give the patients, and we have an OMFT trainer inside our team which will take care of this. And typically they need to be motivated, they need to be monitored so that they do these exercises properly. But if these exercises are done very well, the results are very good. The muscle tone is enhanced. So for children, we give some kits like this to make it more interesting for them. So dental intervention is key when it comes to residual anatomic and habitual factors of OSA remin. So what I tell my patients is, see, basically this is a multifactorial problem. So the approach is multidisciplinary in nature, and the approach protocol of the treatment is multimodal in nature. That's how I explain it to my patients, and that's how we need to work on this. So So alongside, we need to have a multidisciplinary approach to this issue. This is a small video on the finishing note for the audience here. Thank you. Thanks for giving me this opportunity to be here. I'm an XYZ person inside this crowd. Or maybe one or another dental professional. Probably Shankar's wife is another dentist here, I think, now. Thank you. Thank you.
Thank you, sir. Thank you.
Sleep apnea. And you know, after surgery, I realized after 2-3 weeks, the parents come back saying, still opening the mouth. So then I realized we should start myofascial or dental. I just started realizing late in my life, but I have started it. I must tell you that. Habit, yes, habitual. I know when you said it, I think I must tell the crowd also. I wait for 3 weeks actually for the child to get over it. Then we tell them maybe it's a habit and we try to address it. Thank you.
What happens is, people think when I subject them to the ENT, they think that the adenotonsillectomy is suggested by the ENT, the procedure is done, the child is going to be completely relieved of the problem. Then I tell them that's the starting point for this. You are in the journey, in the process of completely, that's the starting point. That is a long way to go for you.